So I'm Justin Jordan. I'm one of the neurofibromatosis doctors at Mass General, and I'm going to talk to you a little bit about pain in schwannomatosis, which is a very common problem that people will sometimes demonstrate. So we'll talk a small amount about schwannomatosis, although Dr. Na gave us a really wonderful overview. We'll talk about the mechanisms of pain in schwannomatosis, and then we'll talk a little bit about some of the clinical trials that we've seen in this space. So we just heard about the new diagnostic approach or rubric to schwannomatosis, where all of the disorders that are predisposing individuals to schwannomas are under the same umbrella, and then we subdivide them by the gene that has caused their schwannoma predisposition. So in that we have NF2-related schwannomatosis, SMARCB1, LZTR1, 22q. You just heard Dr. Na explain this beautifully. So among this, because of the long-standing nomenclature we had before, where we talked about NF2 as a separate entity, and because of some similarities and some differences between the groups, many of us think in terms of NF2-related schwannomatosis and non-NF2-related schwannomatoses, and that's a group of disorders which looks like SMARCB1, LZTR1, 22q. We think about those as a bit of a group because they have more similarities amongst themselves than with NF2-related schwannomatosis. So among those, they are similar to NF2, an autosomal dominant group of disorders, meaning if you've got the disorder, there's a 50-50 chance for every child you have of passing it on. But different from NF2-related schwannomatosis, if you inherit NF2, you definitely have the disorder and demonstrate tumors and the entire phenotype. That is not the case with the other schwannomatoses, where you have a 50-50 shot of inheriting the gene mutation from your parent, but there's a chance that you may never have symptoms. In genetics, we call it penetrance if you have symptoms of a gene change. And so in this case, we say that this has incomplete penetrance, which is different from NF2-related schwannomatosis. And lastly, Dr. Na showed us a beautiful MRI scan of somebody with bilateral vestibular schwannomas, hearing nerve tumors on both sides, and told us that that was the hallmark of NF2-related schwannomatosis. For the other disorders, that's the exception to the rule. So we see multiple schwannomas, but we tend to see them along the peripheral nerves and along the spine, and sometimes the other cranial nerves in the head. Rarely do we see vestibular schwannomas in this case. So the non-NF2 schwannomatoses are much less frequent than NF2-related schwannomatosis. So NF2-related schwannomatosis is about 1 in 25,000 people, and here we're about 1 in a million, maybe up to 25 in a million, but a much lower likelihood of being diagnosed with these disorders. There is, to our knowledge, no race or gender predilection, so you're equally likely no matter what your background is. But recall that NF2-related schwannomatosis tends to be diagnosed in your sometimes adolescence, sometimes teenage years, early 20s. It's usually quite a lot later for somebody with non-NF2-related schwannomatosis, where the age of first symptoms may be late 20s, first surgery in your 30s. Sometimes people aren't really diagnosed until their 40s or 50s sometimes. And that highlights what Dr. Na pointed out, that the diagnostic journey can be quite prolonged for individuals with schwannomatoses, because sometimes you need multiple tumors to get the genetic changes and so forth. So when we think about the locations of these tumors, about 89% of patients with non-NF2-related schwannomatosis will have a peripheral nerve tumor. 74% will have a spinal schwannoma. A small percent will have some under the skin, which is kind of interesting, and Dr. Walling has studied those specifically, actually. 9% will have other tumors in the head that are not on the hearing nerves. And then Dr. Na alluded to this a little bit, but it's a much rarer instance that you may have the other tumors that we see, including meningiomas. We see some angiolipomas and others. This is from a paper 13 years ago by Dr. Plotkin and Vanessa Merker and others, looking at the numbers of tumors. And you can see patients with NF1 tended to have a heavier tumor burden than those with NF2, than those with non-NF2 related schwannomatosis. I don't have a slide for it, but in case you're wondering, the reason that people tend to have less tumors in schwannomatosis, the reason they tend to be diagnosed later, is because of that really complex chromosome slide that Dr. Na showed, where it takes so many genetic changes for an individual tumor to develop. That all happens randomly, so it just takes time for those second and third hits to happen for a tumor to develop. So pain turns out to be probably the most common presenting symptom among patients with non-NF2 related schwannomatosis. Depending on the data you look at, up to 60 or 80% of people with these disorders may report chronic pain, and an average pain intensity of at least 5 out of 10, which is quite a lot of pain. And I see a lot of nodding heads in the room. Most people are living with chronic pain by up to 15 years by the time they're in our clinic. And I've had many patients over the years who have said, I saw doctor after doctor after doctor with my chronic pain until finally the whole thing was pulled together when we realized schwannomatosis was underlying that. It's often the case that pain is nerve-like pain, which is shooting, burning. We call that neuropathic, but not always. Some people can have the throb that you might otherwise think about with arthritis or something along those lines, so it can be a mixture of pain types. And we looked at a group of patients a number of years ago and looked at the genetics of those patients relative to their pain and how the pain in fact impacted their lives, and identified a potential genetic link where those patients with LZTR1 mutations tended to have more pain than those with SMARCB1 mutations. We also identified that patients' total body tumor volume did have some correlation with their pain. So the more amount of tumor in your body in patients with schwannomatosis, the more pain roughly. So does pain get better with surgery? Well, undoubtedly, we have many examples where it does, and we have wonderful surgeons such as Dr. Kumans who have helped us with many of those things. But not every hospital in the world has Dr. Kumans or other wonderful surgeons who are experienced in schwannomatosis, and so it's a little bit mixed. There's here at Mass General, we looked back in 2012 at 86 patients who had undergone 217 surgeries for resection of schwannomas, and we identified that 39% of those surgeries actually alleviated pain. They had the surgery for pain and their pain got better. But 75% of pain relieving surgeries had pain recurrence. I think that there's a couple things to take away from this. First of all, we just talked about the potential risk of tumors coming back. It's also the case that pain is incredibly complex. Sometimes it's difficult for us to measure. It's difficult for us to pinpoint, even if it's in the arm and the arms where the schwannoma is that actually the cause? Could it be a post-surgical pain? There's a lot of different possibilities. And 45% of patients in this series had persistent deficits after spine surgery, many of those being sensory, as we just heard from Dr. Kumans, which sometimes you may come out of a surgery with a sensory deficit, maybe a band of numbness or something. And 27% had persistent post-operative deficits after a peripheral surgery, and this includes in the arms and legs as well. So pain can certainly be improved with surgery, but sometimes the upside may not fully outweigh the downside, depending on the entity. And spinal surgery, specifically, this is from another institution where they looked at 65 patients who had undergone spine surgeries for schwannoma removal. And they saw improvement in function, which they called recovery, in 53% of their patients. 20, I'm sorry, recovery, getting back to where they were after at the time of surgery. So surgery always knocks you down if you have a spine surgery. So they recovered back to their pre-surgical baseline in about half of people. They actually came out better in about a third of people, and then stable or worse in a small group. And that was a little bit different based on whether this was a solitary schwannoma versus patients with schwannomatosis versus patients with NF2. And you'll see that in patients with non-NF2 related schwannomatosis, there were far more lumbosacral tumors that had been removed. This did not come out well there. This is very early data from a survey that Dr. Plotkin and others of us have participated in, looking at pain medication usage among patients with schwannomatosis. This does not translate well, but I'm going to tell you that the takeaway message, in my opinion, is 3/4 of people are taking some sort of pain medicine, and there is no magic category of pain medicine that seems to work. Some people are taking one category, 2, 3. It does not seem that in this disorder, among the drugs that we have available today in the narcotic, the neuropathic, and the anti-inflammatory categories, there's any obvious fix for the average person with pain related to schwannomatosis. Dr. Vranciano has spoken at this symposia in years past. Perhaps some of you have seen her. She's a neuropsychologist with whom we've done work over the years. And she had a study with a very innovative cognitive intervention focused on relaxation, response, and resiliency, where individuals had 8 weekly sessions, 90 minutes long, learning some strategies for living through pain. So this was not taking new pain medicine. This was taking you where you are in your pain journey or your disease journey. It wasn't only for patients with pain. And using strategies for increasing resiliency. And in that, they identified significant improvement in things like satisfaction with life, in stress and depression, but also in mindfulness and post-traumatic growth. So even people who had a lot of chronic pain found non-pharmacologic benefit with these interventions. Now, a few years ago at MGH, we began a study using tanezumab, which is an antibody against a protein called nerve growth factor. It's actually a really fascinating history for this medication, which was first created to help people with arthritis, osteoarthritis. And it worked so incredibly well that people walked on joints that they really had no business walking on. Their pain got better. And so the FDA actually took it out of trials because people needed emergency knee replacements and so forth because they shouldn't have been, they felt so good. And so it was shelved for a long time. Dr. Plotkin worked very hard to get access to this medication. And so we did study it in a group of patients with non-NF2 related schwannomatosis who had pain. The drug company actually stopped producing the medication during our study. So in the end, we got 9 patients enrolled. But I think it's important data. The design of the trial was that for the first 3 months, you had a 50-50 shot of getting placebo or the medication, the tanezumab. And then in the second 3 months of the trial, everybody got the drug. And this really allows us to overcome the risk of the placebo effect, which is very common in pain medicine trials. So in the same individual, we were able to test whether they got better or not going from one arm to the next. And in this group of 9 patients, the pain score reduced 2.5 for those patients who received tanezumab in the first 3 months compared to 0.4 for those in the placebo group. And for reference, this is looking at the scale that goes from 0 to 10 that many of you probably answer in the doctor's office. And statistically, we believe that a change of 1 in that scale is meaningful for a person's life and how the pain interferes with their life. So this is a significant improvement in their pain. But as I said, the medicine is no longer available, unfortunately. So it leads us to our next evaluations, looking at other potential targets for pain. From a variety of sources, it's been identified that a protein called CGRP is associated with pain response in the body and can travel from one axon to the other axon, communicating a pain. And then similarly, IL-6, which is these little green dots that don't show up well on my screen here, are little inflammatory proteins, which are equally potentially important in communicating pain. And from a number of studies now, we've seen that these are important in a variety of pain communication types. This is actually a study of rheumatoid arthritis, where they found IL-6 as an increased inflammatory marker contributing to pain for patients with rheumatoid arthritis. So these two targets are becoming increasingly important in the pain story. And in fact, CGRP is now the target of a number of FDA-approved migraine medications, and that's very helpful for patients with migraines. So working with one of our basic science colleagues, Dr. Lei Xu, she gave some mice schwannomas. She injected schwannomas in their sciatic nerves and looked at the effect of blocking IL-6. So she implanted the nerve here, and then she actually uses a type of pain test where she pokes the foot of the mouse and determines how much it really is uncomfortable for the mouse, generally as an example of how they experience their pain. And when that's the von Frey threshold. When she gives IL-6 antibody to those mice, it actually takes a whole lot more pokes for them to say enough already in the foot that's affected by the schwannoma. So in mouse speak, this looks like IL-6 is an important contributor to pain, and blocking it actually reduces pain quite a lot in a schwannoma affected leg. So based on this, based on the story of the CGRP effectiveness in migraines, this leads us to the current trial that's ongoing, which is called Starfish. The Starfish trial, so named because an arm that doesn't work will be removed and perhaps we'll grow another one. The Starfish trial is for patients with schwannomatosis with moderate to severe pain, and so that means a pain scale of 5 or more. And on this study, patients are randomized between arms. So this is actually a study that includes multiple medications, not just one as we saw in the tanezumab, but there are multiple drugs. One that targets IL-6, that's the one I just showed you we were blocking in mice, that's siltuximab, and one that blocks CGRP, that's erenumab. And so patients are randomized to one of those two arms currently. In the future, we'll add more arms. And then within that arm, they'll be similarly randomized, just like we saw in tanezumab, where there's a 50-50 shot of placebo to start, and then everybody gets access to the drug in the second part. But the nice thing about this trial is you get randomized to one, but then you get to go to the other. And then when there are future arms, you get to go to those. So the idea behind this is not only to determine each medication's effectiveness for treating pain in patients with schwannomatosis, but also for the patient in front of me, what's the drug that seems to have the best effect for them? We're only using medications that are FDA approved currently. So our hope is if we identify a medication that works exceptionally well for a patient, we would work with an insurance company and try to get access for continued care with that. And that's worked relatively well so far. We can't promise anything when it comes to insurance companies, as you all certainly know, but that has been successful for some people. Okay, so in summary, pain is extremely common in patients with schwannomatosis, especially non-NF2 related schwannomatosis, although it applies to everybody. And traditional therapies don't seem to be sufficient Targeted therapies may be possible, and there are new trials underway. And if you'd like to hear more about those trials, please let me know, or Dr. Plotkin, and we're very happy to talk with you. And that's all. Thank you.